Our third speaker is actually Dr. Kareeman Gommaa. She will present, she's an assistant lecturer, and she will present an ICE case in our department.
Good evening, everyone. First of all, I want to thank my dear Professor Dr. Azza Mustafa for giving me the chance to be here today. Our case is about a 1-year-old boy. He has history of recurrent infection and was admitted to the pediatric hospital complaining from severe pallor. His hemoglobin level on admission was 3.5 gram per deciliter, and he received two units of bagged RBCs based on this hemoglobin. On examination, he had a severe pallor, stunted growth, right axillary and submandibular lymph node with no organomegaly. His post-transfusion CBC revealed moderate normocytic normochromic anemia for age, moderate leukopenia with absolute neutropenia and relative lymphocytosis. The reticulocytic count was inadequate to the degree of anemia. His chemistry profile was normal apart from slight elevation in ALT, AST, and slightly low albumin. The viral screen and coagulation profile COMPASS tests were negative. He has a slightly low iron and ferritin level. Bone marrow examination was done and revealed a low normocellular bone marrow for age. Megakaryocytes were normal. Myeloid series revealed arrest of maturation with predominance of the promyelocyte and promyelocyte. There was a vacuolation in the early myeloid precursor, cytoplasmic and nuclear vacuolation. Please note the vacuolation, they were both cytoplasmic and nuclear vacuolation. There was complete absence of the mature myeloid form with predominance of the promyelocyte and myelocyte stages of maturation. This is another picture to demonstrate the vacuolation of the early myeloid precursor. This is an early erythroid precursor showing also cytoplasmic vacuolation. There was also an increase in the blast cell count. The blast cell was 6%. This is a blast cell. This is vacuolation, the early erythroid precursor. Also, the erythroid series revealed mild dyserythropoietic changes. So the final conclusion was a low normocellular bone marrow, vacuolation of both erythroid and myeloid precursor cell, and arrest of myeloid maturation. Bone marrow iron stain was done and revealed low stores with occasional ring sideroblast. Ring sideroblast is an erythroblast with more than 5 iron granules surrounding at least more than 1/3 of the nuclear circumference. Bone marrow picture and iron stain was suggestive of myelodysplasia with 10% ring sideroblast. At this stage, the child was diagnosed as myelodysplastic syndrome with excess blast and was going to be referred to the pediatric oncology hospital. However, pediatric MDS is extremely rare, and we should not verify such a diagnosis before excluding all the secondary causes for myelodysplasia and sideroblastic anemia. This is an algorithm for common causes of sideroblastic anemia. It may be hereditary or acquired. The hereditary causes may be X-linked, mitochondrial, or autosomal recessive inheritance. The acquired causes may be MDS with ring sideroblast with single lineage dysplasia, or abnormal pyridoxine metabolism associated with certain drugs such as isoniazid and chloramphenicol, some with lead poisoning, and some nutritional deficiency such as copper deficiency. So we have a child with marked anemia, absolute neutropenia, bone marrow dysplasia. So we tried to exclude all the secondary causes for such a case. So we revised the drug history of our patient, but his mother denied that he received any of the drug known to cause dysplasia or ring sideroblastic anemia. However, she said that the patient received an antidiarrheal drug that contained zinc for a prolonged period of time. So we thought that our patient may have a case of zinc toxicity leading to copper deficiency resulting in myelodysplasia in the bone marrow. The next step was to assess the zinc serum zinc level, serum cover level, and it was very, very low. It was 8 microgram per deciliter. The normal level is 7 microgram per deciliter. We measured it twice from 2 different samples, and it was very low in both samples. Also, the ceruloplasmin level was very low. It was 5 milligram per deciliter. The next step was to assay the serum zinc level. However, the serum zinc level in this patient was normal. However, when we revised the prenatal and nutritional history of our patient, we found that he had a low birth weight and was fed predominantly on cow milk, and both are 2 risk factors for copper deficiency. Our patient was treated with oral copper gluconate and demonstrate complete improvement of anemia and neutropenia and the normalization of blood count. Our take-home message is copper deficiency is although rare, but it can cause reversible dysplasia, unexplained anemia, and neutropenia. It should be considered in any case with unexplained anemia, with or without neutropenia that show dysplastic bone marrow features with normal karyotype, unexplained peripheral neuropathy, or any cause of malabsorption. Thank you.